Welcome to Global Public Health Podcasts, where we learn from each other about the global and local intersections in health. Hi, I'm your host, Lauren Clark. I'm a professor of nursing at the University of Utah College of Nursing, and I'm bringing to you stories from students with insights into global health. Today we're going to be listening to Jami Baayd talk about her experience as a beginning public health researcher in Morocco. The topic of interest to Jami is maternal mortality and the experience of giving birth in Morocco and all of the disparities that Moroccan women in rural areas face. Let's listen to Jami now.
Hello, my name is Jami Baayd, and I am a graduate student in public health at the University of Utah, and my research interests are in global maternal health and health disparities. I'm going to be talking about the research I conducted in Morocco for my master's thesis and a little bit of background about why I wanted to do the research in the first place. I have some personal ties to Morocco, particularly the rural south, and when I began to look into their maternal health outcomes, I quickly discovered that Morocco, as is the case in many countries, has worse outcomes for women living in rural areas versus urban areas. So a woman who lives in a rural area is twice as likely to die giving birth and is also half as likely to have her birth attended by a traditional birth attendant. So kind of the current maternal health landscape in Morocco is the Moroccan government made it free to give birth at any of the public hospitals, but women in rural Morocco are still in quite large numbers choosing to give birth at home. So I went to discover kind of the reasons behind that and what are some of the barriers that rural women face when trying to seek care at a healthcare facility. So when I decided I wanted to look into these barriers, I realized I was going to have to do qualitative research, and I didn't have, at that point, any experience in qualitative research. I had prior to that considered myself more of a numbers person. I knew I wanted to do focus groups with the women because in Morocco, women traditionally gather in groups and talk about things like childbirth and other women's reproductive issues, so I felt like they would be comfortable talking in a focus group. I was a little bit nervous the day of, but we woke up and started making preparations for the focus group. We baked cookies and prepped the teapots so the women would have refreshments when they come. We had everything ready to go. And by 11:30, no one had showed up. And the members of my research team and our community contacts assured me that Moroccans are known for not being terribly punctual, so I wasn't too worried. But by around 12:30, only 2 women had showed up. We decided, you know what, we're just going to make do with these 2 women, and we practiced using the recorder, and we consented them, and we went through the entire guide with those 2 women, and they were incredibly generous and kind with their stories. But after about an hour, we were done, and I was feeling pretty defeated. And then all of a sudden, the women started knocking on the door, and about 30 women came within the next 15 minutes. Suddenly, our house was incredibly full, and everyone was talking at once, and women had brought their babies, and it was this lovely sort of chaos, and I felt so relieved that we had been able to successfully recruit women to the focus group. And I'll never forget that first focus group I did, where there were little kids crawling around everywhere. There was a rooster crowing in the background so loudly that it actually made our recording hard to hear in parts when we tried to review our transcripts. And then I remember that even though I'm sure it was obvious to the women that my Arabic wasn't perfect and that I was still working out some of these questions, I remember the patience that they had with me and their generosity in sharing their experiences. There were some stories that were shared that were really heartbreaking. Women shared with me how on several different occasions women had gone to the hospital, made the trip to give birth, and not even found a healthcare provider there. Or one woman told me that she arrived during the doctor's lunch hour and they refused to open the hospital, and she actually had the baby on the steps of the hospital, and how disrespected she felt in that moment. And women shared their stories of loss and trusted me to share what they thought could be improved. And One of the things I was most surprised about in my focus group was, I think, even though I had been to this village several times prior, I had preconceived notions about. I thought that because the women didn't have a ton of education, maybe they didn't understand the process of childbirth so well. But I was surprised these women, they really understood childbirth and they had a really clear expectation of what respectful and appropriate maternity care would look like. And they could really quickly identify when they were treated respectfully and when they weren't treated respectfully. One woman in that first focus group told me about her baby who had died, and she told me that she had gone to the doctor several times because she knew that she was well overdue and that they had kind of blown her off, that she requested an ultrasound. They didn't give her an ultrasound. And she said she knew that she was right that her baby was that post date because when she gave birth, she could tell the baby was covered in a lot of vernix, had a lot of hair, that its nails were long, which is in the field of maternal health a fairly advanced thing to understand. But this woman had empowered herself, even though she was barely literate, to understand the process of childbirth and to advocate for herself and her baby. My research in Morocco was driven by a desire to understand why only 55% of women in rural Morocco were giving birth with a skilled birth attendant compared to 92% of women in urban areas. So, the way the maternal health care system in Morocco works, particularly in the rural areas, is that a woman, when she's giving birth and wants to access the free public health care system, she first has to enter at a primary care hospital. So, the primary care hospital that I studied, although it was a very nice facility, was very understaffed and did not have a lot of supplies. So, the women had to go there first. And then, if they had any issues, such as needing a C section or hemorrhaging issues or any sort of complicated birth, they were then triaged to go to the secondary hospital. Again, the secondary hospital was not able to provide C sections. So, at that point, then they would have to go to the third big hospital, which is where the physicians actually are that can perform C sections and help with any other birth complications. So, when I went to discover why so few women were choosing to access the hospital in rural areas relative to urban areas, what I discovered is that women were not at all pleased with the care that they got at the primary care hospital. So the women, one of the findings of my focus group was they were very satisfied if they made it all the way up to the tertiary care hospital, the larger hospitals where they provided C-sections. They felt like the care there was really excellent, that the physicians were well trained, and that they had the supplies they needed. The problem was women felt like if they had to give birth at the primary care hospital, they didn't have the supplies they need. The nursing staff did not treat them respectfully. And they they felt like if they were going to make all the effort to go to a hospital and then find that either it was understaffed or undersupplied, they might as well stay at home. So another one of my findings was that women actually felt very respected and cared for by their home birth midwives. They're actually more of a traditional birth attendant. So when the traditional birth attendant would come, the women told me that she would only come bringing oil and a glass of milk to provide the women strength, but that every woman that I spoke with that gave birth with a traditional birth attendant felt like the woman had confidence in their ability to give birth, and that the traditional birth attendant was really present with the women and cared about them. And that was in stark contrast to the level of care they felt they were getting from the women who accessed the primary care hospital. So transportation was, as often is the case, of another barrier to accessing care at a health facility. The Moroccan government has a provision that women are, if they have to enter the primary care hospital and then be transported to the secondary hospital, they are supposed to be provided an ambulance to take them there free of charge. And the women shared with me that rarely was it the case that they were able to get a free ambulance ride, and that even if they called the ambulance driver, frequently he was busy or unavailable. And so the provision that the Moroccan government put in place for transportation is not successful in the specific rural area where I was looking. So those are the primary reasons that the primary care facility was not adequate to meet the needs of the women and that they didn't have adequate transportation. And this primary care hospital is also an issue because they're required to enter there first before they can go elsewhere. So I heard stories about women who were hemorrhaging, or one woman told me that her baby's foot was hanging out and she still had to go to this, even though it was clear to everyone. She still had to go to the first hospital and get a paper signed, then go to the second hospital, which is about 30 minutes away, get another paper signed until finally she could make, at that point, then between the second and third hospital, it's about an hour to get to the tertiary care hospital where she could finally be treated.
Jami Baayd shared with us today her experience in Morocco. Before she even went, she had to learn how to speak Arabic, and she practiced and read and refined her research approach as much as she could. I was really impressed by her personal dedication to this project and to the women in Morocco. I also took away from the story a sense of gratitude that she felt for the women who took the time to share their stories with her. And all of that was done in an effort to improve the lives of women who give birth in Morocco and improve their health outcomes. I also thought it was very touching that after she left and came back, she spent some time organizing her research findings and preparing them for publication. It's clear to me that Jami's on a path for more education and more activism, and that the lives of women and their babies in Morocco are going to be improved as a result. Thanks for sharing your story, Jami. Thanks for tuning in to the Global Health Podcast, where we learn from each other about the global local intersections in health. I'm Lauren Clark. Thanks for joining us.